There's been a wide range of diseases in parts of Africa in which I've worked that have largely been set to one side and ignored. They are the diseases of the most impoverished people. They have become known as the neglected tropical diseases. These diseases affect millions of people. And one of the diseases we've been working on is schistosomiasis, often called bilharzia. And in endemic areas, that disease affects almost everyone who is going near the water sources. So you're talking about infection rates of 90% or more, and millions of people are infected, particularly in sub-Saharan Africa. And there's been a remarkable development in the last few years, a concentration on these diseases that have been largely ignored, and a possible solution. A range of drug companies have made medications free of charge indefinitely until these diseases can be controlled or even in some cases eliminated.
The problem that we have when we're delivering donated drugs to people who are living in rural Africa is that they are a little bit suspicious. Why is somebody giving us a pill to swallow? At the pessimistic end, it's, is the government trying birth control without telling us? That's one of the obvious reasons. But in fact, we are offering these people medicines, and there are 3 or 4 different medicines which are given every year to everybody in the village. It's called mass drug administration, in order that we will protect them from diseases, the neglected tropical diseases, which maim, blind, and cause a lot of discomfort.
In the research that we have done, we've now worked at about 100 sites across East Africa, in Tanzania and Uganda. One of the things we found out very quickly was that rhetoric about the success of these programs was open to question. That in some cases, people did take the tablets and there were clinical effects. In other cases, they didn't.
Well, one of the things we found is that drug uptake was really very impressively high in parts of Moyo and Adjumani districts in northern Uganda. And that could partly be attributed to the fact that some of those populations were living in internal displacement camps where social life is very regulated. It was relatively easy and straightforward to distribute the tablets, and equally there was an understanding and trust in the endeavours by both government and international agencies by the populations on the receiving end of these treatments. A long, long history of working closely together. Whereas in other parts of Uganda, say for example in Panyuma in northwestern Uganda, which lies on the border with the Democratic Republic of Congo, populations are very, very mobile. There's long history of antagonism and dissatisfaction, if you like, with the Ugandan government, a sense of feeling marginal to political processes, and then out of the blue arrives this program offering to alleviate sickness and suffering and poverty from the poorest of the poor, and a sense of skepticism about that. Well, where has that come from? Why has it come now? And if they're really interested in our health and helping us, why are they not providing drugs for malaria, for HIV/AIDS, for other infections which are much more visible and appear to cause much more sickness?
Look, a really crucial point here is that you have to have buy-in from the population. You know, the idea that you have a vertical intervention where vast numbers of tablets come raining down and people will then consume them in an orderly manner is rather absurd when one begins to think about it. So we have to have much more effective communication.
We've been encouraging them to keep taking the drugs because it's a very positive drug. It has a very great impact, and I think in the process several people actually got to know these drugs are will really help them in the future. So I think my presence in the research also was very important in a sense that was one of the ways of engaging the community because I'm part of the community.
We've worked actually very closely with people at a district level and also at a national level, and in some places there have been some very concrete changes in terms of how the drugs have been distributed. So my understanding is that the way drugs are being rolled out now in Panyuma, for example, is using a slightly different mechanism than was initially planned, using the local councils and not just village health workers, and that's made an enormous difference in terms of building trust and rapport with the Ministry of Health. And as a result, drug coverage has increased.
The absolute key to the results was messaging in the community. The pills were delivered to the school children, but they didn't actually know what they were taking or why they were taking, and the parents were a little bit worried as to what was being given. The messaging wasn't good enough. You've got to be open and you've got to explain exactly what needs to be done, what is being done, and how we do it. And we have improved our messaging as a result. In the community, the impact of implementing recommendations was a change in the number of people who were treated, because they were reached in a much better way, they were given more notice, and they could then make a decision as to whether or not they would come for the treatment.
It's forced the drug companies, in a sense, to re-engage with the communities that are receiving these medicines. So they have to be understood. And by that I mean there are issues such as compliance is a huge issue. Is the medicine being taken or not? What he's done is moved it from a vertical top-down approach to a much more grassroots level debate.
A turning point in the impact of our research was when The Lancet decided to publish a paper that we'd written at a key moment, on the day when all the key donors were meeting together in London. And that piece that we wrote made the point that the current strategies couldn't work. There needed to be much more rigorous engagement, much more serious engagement with the target populations.
I think, if anything, it stirred up the need for interdisciplinary crosstalk and research, sharing of knowledge. I don't think that those particular silos that have been involved in these areas were used to that type of crosstalk. And if anything, that's what it did stir, that you do need to actually have an anthropological viewpoint on these communities. It can't just be medics administering drugs.
It led to considerable debate. It actually led to a discussion in the Houses of Parliament where our research was quoted, and we went in and had to discuss matters with our members of Parliament ourselves. And I think we can see it has had an effect, that it has put that point very clearly on the agenda. And we're now finding that the UK government and other organisations involved in funding these programmes are now requiring more serious local engagement and more serious monitoring of who is actually taking the medications.
As a result of the research that Tim did, the number of people who are receiving these drugs has increased exponentially in the last 6 or 7 years. And I think it's safe to say that over 700 million people in the whole world, not only in Africa obviously, but in the Far East as well, are receiving donated drugs in order to protect them and to treat them against the neglected tropical diseases.
I think we've demonstrated that anthropology has a unique place to play in public health policy and practice, and that it can, that it should be there as a big player in the heart of global health policy and practice. And we've demonstrated that through our work on neglected tropical diseases, that if you allow people to work at a very, very local level and find out what's happening on the ground and allow them to feed back that information, then policies which are designed with the best of intentions can also be revised and reached back out to those people in an effective way.